Dear colleagues, it's my big pleasure to host today's meeting. So we are focused on the GI cancer updates from ESMO 2023. So we have 4 faculty. I would like to introduce a little bit about Dr. Dominik Modest from University Medellin, Berlin, and Dr. Hans Prenen, University Hospital, Antwerp, Belgium, and Dr. Gong Qing from Sun Yat-sen University Cancer Center, Guangzhou, China, and myself, Ruihua Xu, from the same situation, Sun Yat-sen University Cancer Center, Guangzhou, China. So it's my big pleasure. So I would like to say hello in Chinese. 中国的咱们各位朋友啊，今天呢非常荣幸，我们在 ESMO 的会议现场的我们大家来共同来分享有关在 GI cancer 的一些新的一些进展啊。那今天我们非常荣幸有4位教授一起来参与，他们呢，我想待会都会有每个人会有这个精彩的内容。我就不一一说了。接下来，我想我们就要开始进行我们的这个 presentation. So I would like start our presentation. So I would like to present several interesting abstracts here from the ESMO this year. The first one is the pembrolizumab plus trastuzumab and chemotherapy for HER2 plus metastatic gastric or G-junction adenocarcinoma. Survival result from the phase 3 randomized double-blind placebo-controlled KEYNOTE-811 study from Elena Zhang. So here is the study design. I think many of you are familiar with this designing. The unresectable gastric G-junction patient never exposed to chemo before and HER2 positive, and so randomized 1:1 to pembrolizumab, trastuzumab, and chemo with the placebo and the same setting, Herceptin or chemo. The randomization was stratified by the region PD-L1, CPS, less 1 or more than or equal to 1, and the chemo regimen. So the endpoint is dual primary endpoint over survival PFS. So here's a major slide this year. Dr. Zhang present. This is the intra-analysis 3. We can see the pembro group reach 10 months of the PFS. Versus the placebo 8.1 month. So the hazard ratio is 0.73. These are positive result. Actually, so we see the interim analysis too. So it maintains the same benefit from here. And the PD-L1 subgroup, we see the CPS more than or equal to 1, also favor pembrolizumab combination. So the adverse events that both arms are quite similar. So there's no new unknown adverse event occurred. So summary, the additional pembrolizumab of the first-line trastuzumab and chemo led to meaningful improvement in PFS or OR, particularly in dual HER2 and PD-L1 overexpressed tumors. AE incidence was similar between arms, and all observed adverse events were as expected with no new safety concern identified. This data resulted in approval of pembrolizumab, trastuzumab plus chemotherapy as first-line therapy in patients with advanced resectable or metastatic gastric cancer with HER2 and PD-L1 overexpression in Europe. The KEYNOTE-811 is continued as planned, and the final analysis of OS will be performed per protocol. The second abstract, this is a new adjuvant setting from the chemo, IC, immunotherapy, PD-L1 inhibitor, so combination. This is an interim analysis phase 3 mechanism. So this started the design. So we see mechanism, a global phase 3 randomized double-blind placebo-controlled study. These are like resectable disease, no prior therapy at all. So stratified by the region, lymph node status and PD-L1 status. The patient randomized to 1:1, development plus fraud, the surgery, and then adjuvant setting. So the placebo, this is quite similar schedule. The primary endpoint is EFS. So this is the pathological complete remission. So we see the development plus the fraud in adjuvant preoperative setting. So we see a higher central review, the higher response rate. We see almost 12 months more than the placebo. Investigator assessment is quite similar as the central review. And the combination combine the complete and the near complete pathological response. We see the 27 in the development setting and versus placebo 14%. So it's also statistically significant. So the safety and tolerability is quite well for, of course, most of the advanced event are from the chemotherapy. So conclusion, Mesalon is the first global phase 3 randomized double-blind study assessed per pre-operative development plus plot in participants with resectable gastric cancer or G-junction. At this pre-planned interim analysis, additional of development to perioperative fraud demonstrated as statistical significant and clinical relevance improvement in PCR versus placebo. Adverse event in system were similar between two arms, and observed adverse were as expected, with no new safety concern identified for development plus chemo. The Mesalon study is ongoing for primary objective of EFS. So these are the gastric cancer, either tislelizumab plus chemotherapy versus placebo plus chemo as first-line treatment for advanced gastric or G-junction cancer. So final analysis, the result of the national 305. So myself, I present myself this in the meeting. So here is the study design. Also the locally advanced unresectable or metastatic disease, never exposure to the chemo before, so no HER2 positive disease, and so randomized 1:1 to tislelizumab chemo or placebo chemo, and stratified by region, peritoneal metastasis, PD-L1 expression. So endpoint is the primary endpoint, overall survival in PD-L1 score more than or equal to 5% and ITT population. So here is the most important slide. So we see the ITT population. We see this group, so can reach 15 months of survival and versus placebo 12.9 months. So the hazard ratio 0.8 statistical significance. So we see the patient even 2 years, survival rate 32% versus 23% control. PD-L1 score more than 5. This is the final, like the update. We can see the continued benefit from the tislelizumab in this PD-L1 positive population. So the progress to progression survival and the tumor response, they see progression-free survival, the T9 months to versus 2.2, the hazard ratio 0.78 is also statistically significant. And the response rate is similar. The T is a little bit increased. And also the response duration of the response also favor tislelizumab group. So the safety profile is quite well. The tolerance, the profile is good. So no new concerns found. Conclusion, tislelizumab plus chemo produces statistically significant and clinical meaningful improvement in overall survival versus placebo chemo as first line in patient with advanced or metastatic GE junction ITT population. Tislelizumab plus chemo continue to demonstrate clinical meaningful improvement in overall survival in patients with PD-L1 score more than or equal to 5, with longer follow-up, the final analysis. The safety profile of TIS chemo was manageable with no new safety signal identified. So this data suggests that tislelizumab chemo presents a potential new first-line treatment option for patients with advanced GC or G junction cancer. Thank you. I would like to introduce Dr. Modest to have the presentation, please.
Thank you very much. These are my disclosures. I'd like to start with CodeBreak 300, which was a presidential session presentation of this year's ESMO. The trial is a bit complicated as it's a phase 3 with only 160 milligrams, which were 160 patients, which were split in 3 arms, 2 experimental arms with different doses of sotorasib, 960 and 240 as experimental arms, both compared with standard dosing of panitumumab. The control arm was investigator's choice, trifluridine tipiracil or regorafenib. The primary endpoint of this trial was progression-free survival in the intent to treat population. And a bit of unclarity arose about the split of the alpha. As far as I understood, 2.5% alpha were reserved for each of the experimental arms. If this was right, the 960 milligram is clearly positive versus the investigator's choice comparison, whereas the lower dose of sotorasib is of borderline significance. However, we can conclude that both experimental arms outperform the investigator's choice chemotherapy in this analysis. What was debated controversially was the overall survival, as depicted on this slide. The higher dosage of sotorasib provided at least a trend with a hazard ratio of 0.77, non-significant, versus the control arm, whereas the lower doses of sotorasib clearly did not. Of course, we have to take into account that the small sample size of this trial was maybe absolutely insufficient to observe proper overall survival. And also the event rate with 34% deaths observed was clearly not ready to be a final analysis. However, as far as it was reported, the final analysis of overall survival will be conducted with 50% events, which is only 16% more than now. And I think we cannot be too optimistic that these numbers will change substantially. So I think if we kind of speculate a bit into the future, we will end up with a trial that was too small to demonstrate overall survival, has a little event rate to demonstrate as such, and will come with a clearly improved progression-free survival in a further line setting of metastatic colorectal cancer. The safety profile was quite relieving. If you combine drugs, you always fear some kind of interactions. I think to make it short and in conclusion, there were little grade 3 or higher events in all of the treatment arms. I think as expected, little serious events. And the safety profile was super consistent with what we knew from panitumumab. We have been using these drugs for decades. And also sotorasib, as we've learned from monotherapy arms, so there's no concern in terms of safety to combine these 2 drugs. So conclusions are a bit diverse. First, and that I think is the most important message, Cobalt 300 met its primary endpoint for superior PFS versus the investigator's choice therapy in metastatic colorectal cancer. And of course, we have to add with KRAS G12C mutation. The doses both provided an improvement in PFS. Whether this was clearly significant with the split alpha or not does not matter much. I think we can all conclude that the dose of 960 milligram was clearly demonstrating a more clinical, meaningful benefit. And I think it's quite clear that this dosage will proceed to the further development, whereas the lower dose will not be developed further. The trial also, we didn't show the data, provided higher objective response and disease control. The OS, as said, was immature, and I'm a bit pessimistic that some more events, not more needed, will change the picture. Safety concerns were not observed, and of course, the combination is effective and needs to find a place among other further line regimens like the Sunlight trial. Another trial that I like to present is also complicated. So it's a day of complicated trial design. It's Cairo 5. It comes as one trial, but the truth is it's two trials. And I quite like what has been done. It was addressing initially unresectable colorectal liver metastases that were per panel evaluation confirmed unresectable. And they split the whole population in two populations. One was EGFR sensitive, that was characterized by BRAF wild type and left-sided primary tumor, whereas all other combination of markers, meaning driving mutation and or right primary sided tumor, were put into the other part of the trial. The key question of the trial for those patients that were sensitive or deemed sensitive for EGFR was doublet PANI versus doublet BERA, whereas all other patients received either the triplet FOLFOXIRI plus BEV or a doublet, which was FOLFIRI or FOLFOX plus BEV. I think it's important to say at that point that nearly 90% of all patients chose FOLFOX when the doublet was the backbone. The primary endpoint of this trial was for both parts of Cairo 5, progression-free survival with a hypothesis of a hazard ratio of 0.7, which I think was a quite strong one. And we have diverse results. For the first part of the trial with the EGFR sensitive tumors, the trial was closed for futility, so it was a smaller trial than expected. They observed a higher objective response rate, although the same secondary resection rate, which was 58% in both arms, and no alteration of the overall survival. For all the other patients, those that had combination chemotherapy versus the doublet, the message was a bit easier because PFS was clearly improved, objective response rate was clearly improved, secondary resection rate was clearly improved, and just the overall survival fell short of a clear demonstration of overall survival benefit. I think we can conclude on the safety profile that it was as expected. So in conclusion, the Cairo 5, and I think that's the merit, is the first randomized trial that prospectively evaluated systemic induction regimens with initially unresectable colorectal liver metastasis as defined by a central liver expert panel. I think the definition the panel used is maybe part of the discussion that needs to be done on the trial. For right-sided or mutated tumors, FOLFOXIRI plus BEV demonstrated superior short-term endpoints as mentioned. I think that OS was not influenced may have different reasons. The trial was not powered to demonstrate this effect, and the high rate of secondary resection, and this is accounting for both parts of the trial, might have additionally biased the further outcome massively. For the left-sided and or RAS-BRAF wild-type tumors, the PFS endpoint lacked support from other trials upfront and was likely to end in futility, and this is what happened. Objective response was better with panitumumab. Resection rates were high in both arms with 58%. PFS and OS were without difference. And I think due to the early termination of this part and the endpoint that was, I think, futile from the beginning, conclusions are less robust in this part of the trial. The last trial I'd like to present is the Pegasus trial, which is also complicated. So it's a bit funny today. However, the idea was pretty simple. The Italian colleagues addressed patients with high-risk stage 2 or stage 3 colon cancer. Post-surgical liquid biopsies were used to identify patients at risk. The trial design, as depicted on this slide, is really hard to understand. So we start on the left. We had colon cancer. There was a post-surgical liquid biopsy 2 to 4 weeks after surgery. If it was positive, the colleagues started K-box for 3 months. Then again, they made an assessment of liquid biopsy. In case of continued positivity, the treatment was changed to FOLFIRI. In case that turn of positivity to negativity, so a clearance of positivity of ctDNA was achieved, the treatment was de-escalated to CAPE. For the patients that were initially liquid biopsy negative, they started 6 months of capecitabine, which is maybe a questionable decision, but I think it was a conservative way to start. And only in case that these patients would switch to ctDNA positivity after the 6 months, they would escalate to a platinum-based regimen, whereas if the patient stayed ctDNA negative, follow-up was done. I think the results of this trial are not too practice-changing, though quite interested. At a median follow-up of nearly 2 years, 10 relapses have been observed. That was 2 local recurrences and 8 distant relapses. And these were partly in stage 3, and also in high-risk stage 3. So this is, I think, something that is of note. What else can we learn from this Pegasus trial? The minimal residual disease rate of 1/4 is similar to data that we knew. A strong prognostic effect of the ctDNA was confirmed in this population. I think we have confirmed that in so many populations that anything else would have been a big surprise. At a median follow-up, 10 false negatives have been observed. For definite conclusions, at least 2 years of follow-up are required, which are not fulfilled yet. And I think very, very importantly, and I think this is my major takeaway of that trial, a zero conversion of MRD positive patients at the end of any treatment was 40%. So there was a subset of patients that was at a certain point in this trial ctDNA positive, and that was somehow saved by escalating or changing treatment. And the good news was that these patients, if they reached ctDNA negativity, most of them, at least until now, stayed free of cancer. And also we have to take into account, and this might be a very, very important takeaway for the future, that site-specific ctDNA detection plays a role. It is not the same whether the tumor recurs in the liver, the lung, locally, or peritoneal. And maybe also some other features like MSI, MSS, and other biological features will play into that. And I think for future assessments and trials, these will be questions of great importance. Thank you.
So I would like to thank both speakers for the excellent overview, I think, of both upper GI and, let's say, lower GI. I think we can start a panel discussion maybe with the upper GI, and then I think we have to make a difference between metastatic disease and, let's say, perioperative. So let's start first with the metastatic disease. For the ones that are HER2 positive, what will be your preferred first-line schedule? To combination chemo plus trastuzumab, or you're confident enough to add immunotherapy with it?
It's a very good question. So actually, Dr. Zhang Jijiang presented data. So actually, we see the FDA have approved the temporary approved for depend on the interim analysis first. So only the response rate to get improved. So, but right now we know EMA also get approved depend on this data, the PFS. Of course, I think the most important issue is the HER2 positive PD-L1 more than 1. I think in this population, I think we may have a consensus to take it as a standard of care. So change the practice. But for the PD-L1 less than 1, so we still need to discuss or waiting for the final result of the OS. This is my understanding for this trial.
Mm-hmm. And luckily, I think most of the HER2 positive are also PD-L1. There is some kind of overlap. So
yes, overlap a lot.
Yeah. Mm-hmm. And then maybe you have, Dominik, you have something to add on this?
I couldn't agree more. I think it's a rare situation that approvals come with short-term efficacy endpoints in a disease with a prognosis of clearly less than 20 months, or maybe in the range of 20 months. So this is usual in observation periods where you can ask for overall survival for definite conclusions. So I was a bit surprised when all these accelerated approvals came. I mean, they came while the trial was running, which I think is a quite unique situation. I think so far we can conclude that the efficacy is very consistent. And I think also the prolongation of PFS is in a range where it would be rather surprising that OS is unchanged. Yeah. However, if that happens, we're in big trouble, to say the least. So I'm not totally and finally convinced, but I think it's right to offer that to patients now. And I think the higher the PD-L1 score is, the clearer that idea should be.
Yeah, and I think one of the difficulties is actually the PD-L1 scoring, because you presented nice data on tislelizumab. We know we have now pembrolizumab, we have nivolumab, but the cutoffs in all these studies are different. So I think in this study, tislelizumab, do you think we need to take a cutoff? You see that the higher PD-L1 is the better the response, but it seems with low PD-L1, they also seem to have benefit from immunotherapy.
So tislelizumab, the rational 305, so the cutoff the 5%. So this is like the more used in the advanced disease. Like the nivolumab also approved in the EMR for this population. So it's quite similar. It's 5. But of course, for the 8-11, so they're a little bit different. So we see many, like even from the pembrolizumab new trials, I forget the name, checkmate 829 or something like that.
I can't remember all those numbers.
Yes, so many numbers. Yes, so they also they get it. Of course, improve the survival statistics, but also keep the benefit in the subgroup with PD-L1 population. So
what percentage of this population? HER2's
usually have
HER2 positive
50%.
Mm-hmm.
So in rational 305, around 50. So.
Yeah. Because it would be easier in clinical practice if we say just if you see some positive PD-L1, give immunotherapy. I think that would be much easier.
A little bit the challenge I think for the FDA. So now the nivolumab. So I know in US they have the all-comer indication label, but in EMA they only 5%. So I don't know, should we all like to FDA change the label? Mm-hmm. Depending, we accumulate a lot of data. Yeah, only actually, so we see when we discuss with the states like the physician, the oncologist, the GI oncologist, they may like to, in the practice, they will like to have cutoff.
Yeah.
The priority for that subpopulation.
But I think the good thing is that we have access to different drugs now in first line, metastatic gastric or upper GI cancer, let's say.
So more choice.
Yeah, so that's a good thing.
Very good, yes.
Yeah. So if we move further to the perioperative setting, because in Europe we already give for a very long time chemotherapy perioperative, while sometimes in the US they gave a lot of adjuvant, let's say. So I think perioperative FLOT is now quite standard in most part of the world. So we're quite happy that now we might be able to add immunotherapy to this.
Yes.
So are we ready to add durvalumab as well for the perioperative setting or not yet, and why?
So in my understanding, at this moment we do not have enough evidence to change our practice yet. So maybe we need to wait for the longer follow-up from the method.
Yeah, so Dominik, we see an effect on response. That's what we see with other trials as well, but it doesn't always reflect outcome.
Yeah. Okay, generally, I believe in response. Maybe that's a colorectal cancer issue with me. However, I would argue these are signals.
Sure.
I could have imagined of greater signals, to be pretty honest. I mean, it's significant, but more due to the fact of numbers in the trial than that was the difference itself. So the benefit so big. So there's a signal, and it's quite logic. The trials are rather big trials in terms of numbers, so I think they have a chance to meet PFS or DFS endpoints. However, I wouldn't bet on it because there are also a lot of patients in that setting that will be cured, so they won't have events, which is nice for the patients, but bad for the trial statistics. So to prove a definite improvement, I'm still a bit skeptical, and I think it will really depend on the selection of patients. So I think the more and more aggressive selection for higher PD-L1 expression is done in the trial, like also in the German trial, which is ongoing, DANTA-3. I think these cuts will likely define how big the effect in time to event endpoints can be.
Yeah.
So I'm a bit.
But still, I think it's the main advantage is I really like neoadjuvant trials. Let's say that you can indeed see these signals, see also what happens in the resection specimens. You can do a lot of translational research on this, of course, as well. But whether it translates into outcome, that just depends on whether disease will recur elsewhere in the body, yes or no, of course. But the high pathological complete response are, I think, encouraging, but not practice changing at the moment.
Unfortunately, in this year, Dr. Chitana also updated the perioperative trials for the pembro combination. The chemo, the backbone is the cisplatin plus FFU. So the pathological CR rate also increased. Unfortunately, the EFS not reached the statistical significance. There's a big change. But unfortunately, it is not reached the p-value significance. So I don't know. So we should wait for the best one.
Yeah, probably indeed.
Sure.
So in OPG, when you do like a neoadjuvant treatment, do you think the organ preserving issue just like a very low and surgery? If you think organ preserver, so maybe the PCR will be very important.
Yeah, it's a good question.
That's a very dangerous question. It comes from a surgeon.
Yeah.
So I think in general, organ preservation has gained a momentum in many diseases. Also in esophageal cancer, that was also an abstract, which I think was highly conflicting. But I think in the end, it will not be our decision. It will be the patients that drive us to deal with that situation. For gastric cancer, to be pretty honest, I'm not so sure whether this is easy. I think we can only kind of recommend this if we establish follow-up methods and algorithms that make sure that we don't overlook a relapse. And I think in rectal cancer, it's not easy, but it's makeable. You have MRI, you can kind of touch it. You can touch. I mean, any surgeon that is asked how to detect rectal cancer will say, well, touch. You cannot touch stomach cancer. This is a bit more difficult. So we rely on endoscopy, maybe on biopsies that are super imprecise in gastric cancer. So I'm a bit skeptical, but I think we will not be able to avoid that question on the long run.
Yeah, and
however we manage them.
I agree also in esophageal cancer, because you mentioned the abstract that was presented, but they put adenocarcinomas on top of squamous. And I think for squamous, I feel a bit more confident because of the high response rates also on radiotherapy. But for adenocarcinomas, I'm also not sure whether I would take the risk to it.
Maybe also in these super aggressive cancers. I mean, we know from rectal cancer, which is like a model, I think now for GI cancer, if we wait, we don't lose life. We can wait, we can control. If we see regrowth, we can save. So this is not proven for upper GI, and upper GI is clearly much more aggressive. So waiting for complete remission can end up in total failure. And I think this is, for me, the major caveat why I'm a bit reluctant, but I know I have to deal with it in a few years. This will come up.
Actually, there are two models. So in like the Western, more doing like neoadjuvant and adjuvant perioperative. But actually in Asia, in Japan, China, or Korea, we more do like to resect and then adjuvant setting. So that a little bit different. So
many patients will ask for preoperative therapy then.
From the method we can see, like Dr. Gong Chen, you mentioned, you asked a question. So actually we can downstage very well. Like to T0 or N0 more after the resect in the neoadjuvant with the immunotherapy.
I think we nicely discussed, especially in upper GI now, what might be practice changing and what might not be practice changing. I think Dominik already mentioned rectal cancer, so we can maybe move a bit lower to the colon part of this talk. So I fully agree that these three abstracts that were presented is the ones that are worthwhile discussing. We had a lot of discussions on ctDNA, but maybe focus first on the presidential session discussed by Filippo Petrantonio. We know G12C, that inhibition is feasible, and it came from the lung cancer patients. But now in colon, we're also quite excited to see some responses. So I fully agree to do this kind of trial. But do you agree, Dominik, that we should keep this combination in this very late line, or would you rather go earlier for this combo with, let's say, anti-EGFR plus KRAS inhibition?
You put me in great danger.
Yeah.
I think there are many truths and many answers to that question. In general, the combination G12C, EGFR will come how it will come. So the key question is sotorasib the strongest G12C inhibitors? We don't know. We don't really believe. There might be other inhibitors that are stronger than this one. That's for the first. So this might have not been the end of the road. That was the first randomized trial, the biggest data, but it's just the first of many to come. And basically, if you're just mean, and sometimes I like to be mean, if you have control of a tumor in a late stage, expressed by a PFS, and you do not manage to translate that to OS, how likely is that if you treat much further and have longer time to lose the treatment effect? Based on that, I'm not convinced. The good news is combination chemo plus G12C, in this case sotorasib and panimab, is well combinable, it's tolerable, so it will be tested. But seeing this kind of slight discrepancy in short-term versus overall survival efficacy, I wouldn't bet.
But I think what we learned also is that we knew this actually already from the phase 1 trial, that you saw response differences depending on dose. And I think what we learned here is that the high dose seems to be the better. Of course, it's not statistically significant, that I know, but you see clinically a bit more meaningful, let's say, the higher than the lower dose. So who knows, maybe if you have more patients in, maybe even better selection, because still we know that not all of them respond. So it's about 40% that responds to the combination. So maybe if we can hyper select like we do for anti-EGFR, that we have a group that will respond to this combination.
So my question is here. So we see the data, the 26 or something like response rate, PFS is good. But overall survival did not separate with the combination. Will this change our practice, or this based on these trials will be approved for the new combination?
I don't think it will get approved based on this data. That's my personal opinion.
I'm also a bit skeptical. However, I guess that the trial was registered upfront, so there must have been a discussion on this overall survival issue. And I think the discussion can also be put the other way around. The control arm is not what we do. Usually now when we give trifluridine tipiracil, we would add BEV. So we have a third line standard, and based on the available data, I would say these data do not compete yet. Could be. But for now, trifluorine tipiracil plus BEV is a good standard for refractory metastatic colorectal cancer. Whatever comes after that is interesting, and I would include these data into these interesting things to do then. So these data will not prevent me from using that, but I'm not convinced that this is kind of a third-line standard instead of the sunlight regimen. I would put it this way. And I think
still responses are quite high for a chemorefractory population.
That's the good news.
Yeah. So
the bad news is it doesn't work long.
If it's available, I mean, your drug is availability is good. So when you treat your patients like this one, G12C mutated, and after all standard care is failed, so you will choose this one. And if you look at the paper in the New England Journal of Medicine, and you will find in the control arm, there is about 20% patients, the efficacy is not valuable. So I don't know why. But in the study arm, this percentage is very low.
Yeah.
One is 1.9 and anyway less than 5%. But the control arm is much higher.
Yeah.
Plus they progress immediately or die even before.
But
they
just say,
manage the CT scan.
don't assess the efficacy.
And maybe they died before the efficacy could be assessed.
Before they got a CT scan.
Several survivors.
We give a suggestion for for the this is MG, right?
Yeah, MG.
MG. So we give suggestion like to the steering committee. So what is the label should we do? How to do the label for this?
So basically, in Germany, where I practice, the situation is substantially different because it's labeled for lung cancer. Yeah. So it's available.
Sure.
So usually if we find such a patient, we apply for reimbursement at the authorities. And up to now, this was usually granted very quickly. Yeah. So we did this very regularly as off-label treatment in selected patients. So we all have, apart from the trial, some kind of experience. And this experience is quite differential. So great successes and also failures. So I would continue to use that. I agree with you, Hans. Label is not guaranteed.
No.
And do you think so many KRAS G12C inhibitor like sotorasib and adagrasib from Mirati and Professor Xu just present a local inhibitor from China?
I did one.
Gastrointestinal. So do you think everyone will be different?
Yeah, there are many more coming out. So I had also a discussion with another company today that has different inhibitors. Let's say the ones with G12D as well. So there are more coming. So I agree with Dominik that it might be that there are some stronger drugs, maybe with better PK profile. The good thing is that we know that in colon they get resistance partially through activation of EGFR. So we combine with EGFR, but there are also other mechanisms that lead to resistance in many other pathways. And this has been shown as well at this conference and previous conferences. So the question will be, who do you have to treat with this combo, with the triplets maybe, or quadruplets maybe? So we'll see in the future how this one goes.
So should we, the MG should do another phase 3 trials, to get indication. So you can use the only off-label right now. For some
phase 3 trial.
There are other phase 3s ongoing also in earlier lines. So I think we have to wait those trials before we can routinely recommend it. I think.
Agree.
So maybe focus a little bit on ctDNA, because that's what you heard for, I think, years now. That is especially in minimal residual disease to detect. And I think everybody agrees that as soon as you find ctDNA post-operative, especially surgeons will know this as well, is not a good thing. So the chance of relapses are quite high. I think for me, one of the issues is how to test that, with which test, which sensitivity. Do you test for a big panel, small panel? I don't know, Dominik, do you have any opinion on the ctDNA detection method?
Many and non-definite. I think patient-informed is maybe the most valid, I would say. Other people are arguing that irrespective of the tumor DNA or architecture in terms of genomics. You can use methylation assays that are specific for colon cancer.
Yeah.
So many ideas on the way.
Yeah.
I was a bit concerned by the discussion of Chiara Chimolini today, which I liked a lot. As she pointed out that the sensitivity and the specificity of these assays are, and I've been suspecting that for quite a while, and I've also been calculating that. It's a bit sometimes a self-betrayal what we do with these things. It's too good to be true. We hate adjuvant therapy to be given to everyone, so it's a pain for us. It's a pain for the patients that are treated without any reason because we cannot identify them. So we've jumped on the ctDNA, however they perform, to get out of this dilemma. But I think the number and the precision is greater than everything we had. But I think we have been kind of convincing ourselves that it's a black-white decision. It's clearly not a black-white decision. I think that's the major takeaway of today. It's not a black-white information. First, and also I think we can also argue, maybe to tease that a bit, is ctDNA a tool to improve the overall outcome of the population? And my personal suspicion is no.
I think it's only relevant when it can change your decision for which treatment to give or how long to treat, etc., and if it makes a difference. But until now, it has. I saw in this one arm that they were treating for 12 months, so in the adjuvant. So this is not standard of care. This also FOLFIRI was in previous adjuvant trials always negative. So now they use it also in the adjuvant setting. So I think they gave it a try to improve the outcome, but I'm not convinced yet that we can use. I find it a very handy tool, but as long as it's with prognostic markers also, what do you argue with prognostic markers? It has no influence on your treatment decision.
Yeah, ctDNA will be the most important, like a tumor marker in future, in 5 or 2 years later. But the first thing we have to standard the technology. You know, so far we have so many technology to detect the MRD. You can do methylation, you can do mutation, and I know from today's precursors, they may be using to combine mutation and methylation. Mm-hmm. So if you, I think before you move forward, maybe the most important thing you have to know which technology will be standard.
Mm-hmm. Of course, right now, so if we like to define how to treat the patient, like the adjuvant setting, so we still need to conduct a randomized control study. So I don't know, Genia as well. Yeah. But they are used very like the earlier stage, I think
that's quite clever because in earlier stages, we usually have non-indication to treat, and then we pick the patients at risk despite the clinically low risk. Yeah. But in the high-risk patients, all these things get terribly more difficult because you can also discuss neoadjuvant therapy in rectal or colon cancer. And if you use neoadjuvant therapy, the whole ctDNA thing is dead because you treat everyone before you realize whether there's a relapse danger. So I think many questions remain despite
maybe for
data.
For the phase 2 right now, so we can consider, because those patients that these are a little bit controversial, treat or not treat. So maybe that one can hold or not. But phase 3, stage 3, we still need to do more work. So use the new research tumor informed panel, so individualized MRD. So they can they consistent, very consistent with the liquid biopsy with the tumor. So that one, if we can do a randomized control study, with that one, select the patient. So randomized. So they can answer the question. So at this moment, it's very tough to change the practice.
I fully agree. So maybe one final question to end this panel discussion. If we have liver mets unresectable, Dominik, so let's say that you're hypersensitive to anti-EGFR on the left side, you're still convinced that we should go for anti-EGFR to get high responses.
Yeah. I am.
Okay, that's. I think it's a very good answer.
The results of CARIFAB cannot change our clinical practice.
Yeah.
So for left side, wild type, for doublet plus EGFR antibody will be the preferred. The others will be triplet plus bevacizumab.
Okay, and with this last words, I would like to thank my co-chair and also the two speakers. I think it was a very fruitful discussion, and I hope you had a good update on ESMO for 2023. Thank you.